Assalamu alaikum. Thank you very much, my dear friend, Professor Asli, and my friends in Algeria for inviting me to give this talk on a quite complex subject. And I hope in the near future to see some of you in Athens for the experts in stone disease meeting, and also to be able to come in person again to Algeria, which I enjoyed very much every year in the pre-COVID times. Allow me to share my screen. So the complex topic I'm going to talk about is nutrition and stones, a topic that is not very enthusiasm of most urologists, but nevertheless, it's important to understand and to practice if you can. Now, I have no conflict of interest to declare. Now, the approach of nutrition to stone disease is to trying to break the circle of recurrence. So you have your first stone, the stone is removed. You may give some form of preventive treatment, mostly drinking. You look for clues of any metabolic aberration, and you might send the patient home with some advice on lifestyle and medication. And then comes the next recurrence, and so on, the wheel turns. So if we talk about nutrition and prevention, then we take a risk stratified approach. So first we need to know what are the risks. Now there are clear urinary risk factors, which are a low urinary volume, a persistent either acidic or alkaline urinary pH, leading to different forms of stones, hypercalciuria, hyperoxaluria, hyperuricosuriya, hypocitraturia, and hypomagnesiuria. But there are also lifestyle and dietary risk factors, and this is what this is all about. Most prevalent these days is the problem of obesity, diabetes, and metabolic syndrome. Dehydration is another issue, low fiber diet, high protein, high sodium, high carbohydrate, high oxalate, and a high or too low calcium intake. Comes to it, stress and lifestyle in terms of lack of mobilization. So the underlying principle of dietary measures would be the initial and complete evaluation of the stones first, then identify metabolic risk factors and interpret correctly the 24-hour urine analysis, and then try to achieve patient compliance. Now, if you have obvious reasons for stones, such as parathyroid overfunction, then you see here clearly that the risk of stone formation in red and nephrocalcinosis in blue after parathectomy goes continuously down. So that's an easy one to sort out. Less easy is if you don't have an obvious cause, for example, lifestyle. Now we can see here that the more affluent the countries are, comes to it, they may be in the stone belt, then you get more stones. And this is interesting, a curve from Norway, where certain events like world wars, depression, or the Middle Eastern oil crisis led to a depression, which in turn leads to less affluence in the population, and that in turn led to less stone formation. And here we can see a clear rise of stone formation in dependency on the affluence of the country, which translates directly into the diet. And you can see here also a rise within the countries, New Zealand, for example, USA, within 20 years. So the urinary balance, so that we don't form stones, is dependent on one hand, the acid load, which leads to stone formation, uric acid production, oxalate, fructose, alcohol, which again leads to uric acid production, too much salt and too much calcium. And on the other hand, too low calcium, magnesium, citrate, alkali load, and water may prevent stone formation. Now, on a more general term, patients with stones should be encouraged to mobilize, lose weight, and they should achieve a BMI not more than 27, of course, with respect to age, sex, and body habitus. Dehydration conditions should be managed. A fluid intake of 2 to 3 liters is recommended. It should be neutral pH, clear fluids per day, and the urine output should be at least 2 liters per day. Salt should be limited to 4 to 5 grams per day. Keep in mind that salt is in all sorts of industrially produced food that goes from tin food to frozen food to restaurant food to takeaway food to junk food and so on. One hamburger in McDonald's has all the salt you need for the whole day. Animal protein intake should be limited to 1 gram per kilogram body weight per day. So for the average male person, that should be 75 milligrams per day. And animal protein is all animal cells, as in red meat, white meat, and fish. The calcium intake should be normal, 1,000 to 1,200 milligrams per day. And generally speaking, the diet should be balanced with low trans fats, low carbohydrates, and rich in fibers, fruits, vegetables. Here we can clearly see on the left side, the upper two curves show men at high risk of stone formation, and those on a low calcium diet, that's the open dots, they form more stones than the ones on a normal calcium, low protein, and low salt diet. And at the bottom, you'll see the one with the round dots. Those are men on a low calcium diet, and with the triangles is a normal calcium, low protein, low salt diet. So normal calcium, low protein, low salt certainly reduces the risk of stone formation in the normal population as well as in stone formers. Now, the problem is that a lifelong commitment is necessary. And please do not forget, appropriate lifestyle and dietary modification should never be abandoned, even when a pharmacological approach is started. So if you put a patient on thiazides or citrates or whatever, lifestyle is part of the A to Z of the advice for a recurrent stone former. Now, this was quite general nutritional advice. Now we come to specific advices, and those are advisable if you find specific risk factors such as calcium oxalate stones, hyperoxaluria, hypercalciuria, uric acid stones, calcium phosphate stones, struvite stones, and cysteine stones. So generally, calcium oxalate stones, which you know are 80% of all standard stones, you advise your patient to drink more than 2.5 liters per day. If they drink mineral water, it should be a high bicarbonate mineral water with a low calcium content. Alkalization of urine can help, but it shouldn't be over-alkaline. If there's hypocitraturia, for example, in some countries like Pakistan, India, it could be endemic, or the patient is bedridden, then citrate supplementation is a good idea. Citrus juices should be the preferred beverages because they have a lot of citrate. but because of the high sugar content, they should be diluted with water. And if you have predominantly oxalate stone formers, then avoid oxalate-rich food like chocolate, sesame, spinach, rhubarb, beetroot, soybeans, tahini, tofu, nuts, peanut butter, okra, yams, and others. But we do usually not do that with patients who have one stone. So this is for recurrent and proven oxalate-forming stone formers. Now, as we have seen in the curves before, a low calcium intake is a higher risk for calcium oxalate stone formation. If there is an enteric oxaluria, then calcium can be taken with meals and binds the oxalate in the gut. Vitamin C is alkalizing the urine and is acidifying the urine and is actually associated with a higher risk of calcium oxalate stone formation. Funny enough, in studies only in men and only if the daily intake is more than 700 milligrams per day. And keep in mind that a combined calcium and vitamin C supplement increases the risk of calcium oxalate formation. In countries like Dubai, even in England, the supplement market is up and rising, and every second of my patients is on some sort of supplements, and many of them are on calcium and vitamin C. So this is something to keep in mind. Now, if you have a hyperoxaluric patient, these are usually proficient stone formers from a young age. Primary hyperoxaluria, vitamin B6, pyridoxine can use as a containment measurement, but usually these patients need later in life a liver and renal transplant to sort out the problem. Now, if there's an enteric hyperoxaluria, as I said before, then these patients need a calcium supplementation of 1,000 to 1,500 grams per day. If their previous intake is less than 500 milligrams per day, citrate can be helpful and magnesium can be helpful. If you have a proven hypercalciuria, there's a cutoff of 8 millimole per liter in the 24-hour urine. If it's less than that, then urine alkalization is recommended. If it's more than that, then you can treat the patient with thiazides. Excuse me. Now, in uric acid stones, of course, proven by stone analysis, the fluid intake more than 2.5 liters, the urine volume 2 liters minimum. It should be a high bicarbonate mineral water, citrus juices diluted with water, reduction as in all stone formers of sodium and animal protein intake, reduction of carbohydrate intake, and in many of these patients, weight loss is advisable. Now, further, we do urine alkalization, but do not bring the pH over 7, because then you run a risk of calcium phosphate stones. So the target pH should be a pH 6. Usually, these patients have a persistent acid urine of 5 to 5.5. And if you have a proven hyperuricemia or hyperuricuria, then allopurinol may be helpful as well. Now, calcium phosphate stones, again, drink enough, achieve a urine volume of 2 liters, low bicarbonate water, low calcium content. If you have a proven distal renal tubular acidosis, then thiazide diuretics lower the urinary calcium level. Acidification of urine, if the patient has a persistent alkaline urine with L-methionine, and the target pH should be between 5.8 and 6.2. If there is a hyperparathyroidism as the primary cause for calcium phosphate stones, and you have to think of that, then you have to check the parathyroid, and of course, parathyroidectomy of an adenoma could be the cure. Now, struvite stones, magnesium, ammonium, phosphate stones are primarily controlled by eradicating the infection and completely remove the stone burden. Again, drink enough, urine volume should be at least 2 liters per day, low bicarbonate water with a low calcium content. And again, these stones form in alkaline, usually bacteria-related urine. So acidification with L-methionine could be indicated, bringing the pH to 5.8 to 6.2. And after you have the patient stone-free, a long-term antibiosis after PCNL, for example, is recommended at least for 6 months. Now, cystine stones, only 2% of all stones. We need a large fluid intake, 3.5 to 4 liters per day, and the urine volume should be more than 3.5 liters, sometimes difficult to achieve. High bicarbonate water preferred, citrus juices diluted with water. If you bring the pH too much into the alkaline area, then you risk, of course, phosphate stones. So try to bring it somewhere into the neutral with a pH 7. And do avoid methionine-rich foods such as meat, fish, and poultry. That means any sort of animal protein or animal cells. Now, that could conclude the talk if we were thinking inside the box where we have thought for the last 50 years. But let's have a quick look at thinking outside the box. Now, on one hand, we have the conventional medicine. On the other hand, we have integrative medicine. And part of the integrative medicine, or functional medicine as it is also called, is nutrition. Now, this is even more important as we live in an area of diabesity or metabolic syndrome. The risk of stone formation is doubled in metabolic syndrome patients. And as you know, there are several traits of metabolic syndrome. With one trait, it's 4%, with 3 traits, it's already 8%, and with 5 traits, it's 10% of stone formation risk. And the risk is reciprocal. That means patients with stones are at risk for metabolic syndrome and vice versa. These stones are mostly calcium oxalate and uric acid. And of course, all comes down to a change in pH of the urine. So the treatment of stones and metabolic syndrome is, of course, treating the metabolic syndrome first, and then address a low urinary volume, too much uric acid in the urine, and address a low pH, drink enough, reduce animal protein, reduce sodium intake. Now, in the urine of recurrent stone formers, high levels of free radicals are present and low levels of antioxidants. And that leads to oxidative stress and ultimately to cell inflammation and injury on the papillae, which leads to Randall plaques and stone formation. These are antioxidative compounds that are used in treatments. You can see some of them are nephroprotective, some of them do actually reduce urinary oxalate and urinary calcium, some of them inhibit crystal formation, and some of them work antibacterial, work on the pH directly, and inhibit tubular crystal retention. Now, if it comes to vitamins, the main players in stone formation, as you all know, is calcium and oxalate. 80% of stones are calcium oxalate, whereby oxalate is the more powerful binder of the two, and hyperoxaluria is a significant risk factor. So if you do have hyperoxaluria proven in metabolic workup, then of course dietary intervention is mandatory. Vitamin B6 can be helpful or supportive also in calcium oxalate stone prevention, but do note that a too high dose of more than 500 milligrams of vitamin B6 is neurotoxic. Now, what not many people know is vitamin A inhibits the degradation of crystallization inhibitors, and therefore is not only the children's best friend, but also the stone former's best friend. And as we have heard before, vitamin C increases the risk of calcium oxalate stone formation, especially in connection with calcium supplementation. Now, if it comes to probiotics, there's something called Oxalobacter formigenis. I'm sure you all have heard about it. It's part of the human microbiome, and it uses oxalate as its sole energy. So it can reduce oxalate absorption in the gut and stimulate oxalate gut secretion. So overall, it reduces the urinary oxalate secretion. So in people who have a high urinary oxalate, this could be a good idea. There are two more oxalate eaters, Lactobacillus and Bifidobacter infantis, but they are apparently less effective. Now, we have talked about supplements. Many people are on calcium supplements. If you have a low calcium, then there is no gut binding of oxalate. The oxalate is absorbed into the bloodstream and excreted into the urine, and that may help with stone formation. So we have to achieve a normal calcium. So in stone formers, of course, no calcium supplementation, and try to maintain a normal input, neither too low nor too high. Other supplements that can be helpful is citrate, which chelates urinary calcium, magnesium, which inhibits formation of calcium crystals, and omega-3, which reduces the prostaglandin E2, which in turn lowers urinary calcium. Now, if it comes to plants, there are two interesting papers, one on red sage, which was tried in flies, Drosophila, but it clinically reduced stone intervention in humans. And the other one is chickpeas, which of course in Algeria everybody knows very well. There was a recent randomly controlled trial on 74 patients on small renal stones, 6 to 10 millimeters over 2 months, a little bit more than 2 months. A quarter were dissoluted and almost half of them were reduced in size. And what the authors found is that this diet with chickpeas increased the urinary volume, so it's diuretic, and it increased also the urinary magnesium, which is an inhibitor of stone formation. Last but not least, as we talk about nutrition, let's not forget the bladder stones. They are endemic with malnourishment if there is no obstruction. They're usually ammonium, urate, and uric acid. The root causes are dehydration, too low protein, and too low vitamins. And the recommendation after, of course, operative taking out of the stone would be a mixed cereal diet, milk, and vitamin A and B. So, as a summary, we can say there is a definite link between metabolic syndrome and stones. Antioxidants can reduce stones recurrences and protect the kidney. Vitamin 6 is helpful in hyperoxaluria. Probiotics with Oxalobacter formigenis can reduce urinary oxalate. No more low calcium diet. I think that message has got through for the last 10 years, but do supplement too low calcium. And citrate, magnesium, omega-3 reduce the risk of stone formation. So lastly, please come to our Experts in Stone Disease meeting in Athens very soon, 10th and 11th of June 2022, where you will hear everything about stones, what you know, what you don't know, and what you never knew you wanted to know. Thank you very much. Shukriya. Salam alaikum.